Hello, my name is Mccray. I'm a second year podiatry resident at NYCPM, and this is my case presentation. The patient initially presented to the ED on September 21st with complaints of a left foot wound after stepping on a nail the week prior. He noticed swelling in the subsequent days, which prompted him to present to the ED. He denied pain to his foot at the time of the visit, and he denied previous history of ulcerations. He denied also doing anything to treat his wound. He did endorse numbness to his lower extremity, and he also endorsed being up to date on his tetanus vaccine. The patient had a significant history for hypertension, hyperlipidemia, diabetes, coronary artery disease, stroke, and a right Bell's palsy, and a past surgical history of coronary artery bypass back in 2012. He endorsed taking insulin, gabapentin, aspirin, Plavix, Crestor, metoprolol, and lisinopril. On initial presentation, the patient vitals were within normal limits. On clinical exam, his pedal pulses were non-palpable, but the capillary refill was intact to his digits. It was within normal limits. He had some edema noted to the foot and ankle. His protective sensation was diminished, and on dermatologically, he had a wound and a blister noted to the submet 1. He had some localized erythema and some warmth noted to his foot. There was some malodorous serous sanguineous drainage, but the wound did not probe to bone, and there was no tenderness upon palpation. So the top left pictures here is pre-IND. You can see the blister, and you can see like the puncture wound site, and the subsequent pictures are after debridement. In the ED, CBC, BMP, blood gas, and also wound culture was taken. His labs were significant for hyponatremia, also elevated glucose levels. On imaging, no vascular calcifications were significant, but no osseous abnormalities were noted and no soft tissue emphysema. Our assessment at this time was a plantar to the submet 1 area, secondary to the puncture wound. He had a localized cellulitis, uncontrolled diabetes. His A1C was noted to be 10.5, and we wanted to rule out peripheral vascular disease. So our plan at this time was the bedside IND debridement and washout, update the patient's tetanus status, continue his home medications for his past medical history, and podiatry plan to take him to the OR for a formal debridement and washout, pending medical optimization. We want to order vascular studies secondary to the non-palpable pulses, and just to monitor electrolyte and follow up with his labs, and also start empiric IV antibiotics and wait for final cultures. His ABI, his right ABI was 1.22 and the left was 1.04, likely falsely elevated secondary to the vascular calcifications. And his arterial duplex was read as no significant stenosis with mild calcification, but the flow was multiphasic. At this point, the patient was admitted to the hospital to continue the IV antibiotics. Cardiology, internal medicine, and infectious disease was consulted for the patient. He was cleared from a cardiology and a medicine perspective, and ID recommended that the patient be discharged with oral antibiotics for 2 weeks. On September 24th, the patient went to the OR with podiatry for a wide debridement of the wound and a washout. They noted about 5 milliliters of purulent drainage. The wound was packed open to drain, and the patient was subsequently discharged that day with the OR antibiotics per ID recommendation, with plans to follow up in podiatry clinic the following week. So we followed the patient with weekly visits while he was outpatient. His visit on October 19th, his wound was declining, it was deeper. At this point, it probed to the capsule and it was positive probe to bone. He had some erythema. So the patient was readmitted for suspected osteomyelitis. The MRI was negative for OM, but at this time, we ordered repeat ABIs, PVRs. At this point, his duplex was significant for left peroneal occlusion, and his ABI changed. His right was 1.26 and the left was 0.91. Podiatry took the patient back to the OR on October 22nd for a repeat debridement graft and wound vac application. At this point, vascular was consulted for the patient, and they ordered a CT angio. The angio was significant for the occlusion of the posterior tibial and peroneal arteries, also the left anterior tibial artery. Per vascular recommendations, they thought that the collateral flow was significant, so they didn't think acute surgical intervention was necessary, and that they would follow up with the patient at an outpatient setting. So during the hospital stay, podiatry saw the patient daily and monitored the wound. The patient was discharged from the hospital on December 2nd after weeks of IV antibiotics per ID recommendations, with plans to follow up with vascular, podiatry, and cardiology in the outpatient setting. On December 17th, the patient went back for a repeat debridement and tegraph application and wound vac application. The patient's first vascular follow-up appointment was on January 20th. They scheduled the patient for a left lower extremity angiogram for the following February and a possible angioplasty pending medical and cardiology optimization. And these pictures are a timeline of his wound. At the patient cardiology appointment, they recommended that he have a stress test prior to revascularization, but the stress test came back as abnormal, and it showed a decrease in left ventricle ejection fracture. And so he was referred to Amherst for cardiac catheterization. The surgery for revascularization was delayed, and this is the progression of his wound. As you can see, on March 7th, it was pretty significant. The patient missed several follow-up appointments, so his first follow-up appointment after his admission to Amherst was on March 21st. And at this point, you can see that multiple toes are affected. On April 5th, the patient was actually scheduled for the angiogram, but the procedure had to be canceled as the patient wasn't medically optimized. His A1C was still elevated, so they rescheduled to allow for time for optimization. On July 27th, the patient finally went with vascular service for intervention. They performed a lower extremity angiogram, and intraoperatively, they found occlusion at the level of the popliteal artery. They found occlusion of the posterior tibial, also the anterior tibial, as well as the peroneal arteries. They performed a balloon angioplasty of the posterior tibial artery. After the operation, they noted that the DPPT and peroneal arteries were all Dopplerable, and also that his pedal pulses were palpable. On August 22nd, the patient went on to fully heal. And there was a recent study published in the Journal of Clinical Medicine that pretty much looked at about 80 patients. And what they concluded was that successful revascularization leads to healing, even in older patient population with significant comorbidities. So in conclusion, I think that seeking vascular counsel and intervention early on for your patients is significant for wound healing. It's also critical. And another thing that I learned was that sometimes maybe the arterial studies aren't exactly reflective of what's going on, so you should definitely seek vascular for your patients to promote wound healing. This concludes my presentation. Thank you.